Holy picture lovers, look at that. Nice job.
Right? Looks
Yeah, like
nice.
way better. Good job.
Mm-hmm.
Mm-hmm. Let's see, what does that mean? Okay. All right, guys, let's get started. I'm recording now. So welcome to today's study group. I appreciate you being here or your note takers being here. Still haven't figured all that out yet, but nonetheless, I appreciate the effort that's being made to come to these and learn about radiology stuff. So we're going to get started. This week, we are talking about radiobiology or the biology of radiation when it reacts with matter, the problems it can create. And let me switch my screen here. All right, can you guys see that okay? Let's see. Can you see that? I'll take your word for it. Okay. So this is group number 7. Okay, very good. So yeah, LSRT group number 7, biological effects of radiation. And we're going to review a little bit of what we talked about last week, the actual X-ray beam. So let's get started. So this is the X-ray beam. This is what we talked about last week. You know that the X-ray photons come down in waves, and suffice it to say that's pretty much what you need to know. The tighter the waves, or the shorter the waves, the higher the frequency. So most of the time we're dealing with really short waves and high frequency X-rays. So just this is the primary beam. It goes through and hits the patient where it attenuates, and this is where scatter happens, where X-ray photons escape the body in all different directions. And it can be very dangerous to us occupationally and also to the quality of our image. So now we see the X-rays coming down out of the body down to the image receptor. That's called exit radiation or remnant radiation. Okay. And we know that most of us, well, all of us use a digital image receptor. So when we take the X-ray, whatever comes through to the image receptor is what it leaves there, a latent image that we can pull up on a computer. Okay, but the X-ray beam is pretty cool. Okay, let's once the X-ray beam hits matter or the human body, there's some interactions that take place, and the main interaction is the photoelectric effect. Okay. And this results in characteristic radiation. Because what happens is the incident photon comes down, hits the body, and it interacts with an atom, hitting one of the electrons in the inner shell right here. Okay, and it hits it square on, and it releases a photoelectron, and that's what we get our image from. Well, one part. We also get bremsstrahlung radiation as well. But photoelectric effect, you need to remember that and what it is. It hits the inner shell and reacts, and what is released is the photoelectron. Okay, and as what happens is one of the electrons from one of the upper shells drop down into that shell to make that atom whole again. Okay. Okay. All right, photoelectric effect. We also talked about the Compton scatter effect. Okay, and as what happens here is our incident photon comes in, hits the atom again, but it hits the outer shell electron. Okay, And as what happens is an electron is released that can be on our image, and this is called the Compton electron, but it also releases a scatter photon. And the scatter photon is what I was talking about when scatter comes out of the patient and can hit us if we're out there, or it can actually go into the image receptor and disrupt the image that we're trying to get. So just remember that Compton scatter is bad, okay? It's the one that can wreak havoc on our contrast on our images, okay? So yeah, that's Compton, where it hits an outer shell, okay? The photoelectron is released as a Compton electron, but it also releases a scatter photon, which can be detrimental to our image and ourselves, okay? We also talked about Rayleigh scattering or coherent scattering, okay? This is where the incident photon or X-ray photon comes in and hits the atom. It doesn't react with any single electron, okay? It basically just hits the atoms, shakes it up, excites it, and a scatter photon is released. Now, most of the time, these are very low energy scatter, meaning the body just absorbs it. So it doesn't do anything to our image because it doesn't make it that far. The body, it's usually absorbed by the body. So coherent scatter. So we need to know about photoelectric effect, where it hits an inner shell, okay? And Compton effect is where it hits an outer shell and releases a photoelectron, but as a Compton electron, but it also releases a scatter photon, okay, which can be detrimental to our image and us if we're out there unprotected. And coherent or Rayleigh scatter, where it hits the entire atom, excites the atom, and a low energy scatter photon is released, which is usually absorbed by the body. Okay, now remember those three interactions with matter. Okay, we talked about attenuation. We learned that attenuation is when X-ray photons actually pass through the body. Okay, and depending on what it is or how big the body is that it's passing through, you know, it depends on bone, really dense tissue. These photons are going to be slowed up. Okay, so not all the photons that start at the beginning of the body go through to the end because they're absorbed by bone or some sort of dense tissue. That's what gives us our latent image. The X-ray or the photons that come through are going to come through as dark. If there's any bone or dense tissue or anything, it's going to be a little bit lighter on our image, just because those areas of the body absorb the X-ray photons, and that's what is called attenuation. It's when the X-rays go through the body and are attenuated by different tissues, leaving us with a latent image on our image receptor. Okay, hope that makes sense. Okay, we also talked about the inverse square law, which basically states the further you get away from the source of the X-ray, the less energy is going to be there. So one-on-one, 40-inch distance, it's going to be the energy that comes out of the X-ray tube. Coming out here to about 60 inches, it's going to be a quarter of the energy. Going out there to 72 inches is going to be about a ninth of the energy. So that's what we use for radiation safety, X-ray safety is distance from the X-ray tube. And we learned that the further you get away, the less energy those X-rays are going to have. So, all right, so let's start talking about the biology of radiation, what happens with the body. There's a little bit of vocabulary in this one. Just be familiar with these terms. We don't do a lot of converting or anything like that, or you won't be expected to do. But SI units are this international standard for units. So sievert is the first one. It's the SI units for dose equivalent, the biological effect of ionizing radiation. Okay, sievert, it measures the biological damage caused by radiation. A gray, a GY, SI unit for measure of the amount of radiation absorbed by a material. Measures the amount of energy absorbed by the tissue. So a gray is the amount of energy that has been absorbed by the tissue or the patient. Okay, a coulomb, it's an SI unit for the electrical charge. Okay, kilogram, we all kind of know about kilograms. It's a measure for a unit of mass. Okay. Dose response relationship, the relationship between the dose of radiation given and the response of the tissue to the radiation. So the dose response relationship. So whatever dose you're given, your body is going to react to that, and that's the response relationship. Okay. Somatic effect, we'll talk more about that in a little bit, refers to the direct physical damage caused to an individual's tissue from a dose of radiation. Remember that somatic effect. It's the direct physical damage caused to the tissue. Relative tissue radiosensitivity, the degree to which tissue is susceptible to radiation. We'll talk more about that one as well. A little more vocabulary here. So a rad, so these terms right here are a little more traditional. And they're very, well, a lot of them are the very same as an SI unit, but they're just named a little bit different. So we need to know that a rad is a common unit of measure for absorbed dose, or same thing as a gray. Okay, REM, REM, a common unit for measure for dose equivalent, or a sievert. Okay, it's just another way of saying it. Roentgen, a common unit of measure for exposure. Okay, now Roentgen, we know that comes from the founder of X-ray, Mr. Roentgen. Anyway, weird name, but it's the common unit of measure for exposure. Curie, Madame Curie, she discovered radium. It actually ended up killing her. She used to carry it around in her pocket. So anyway, Madame Curie, if you ever watch The Big Bang Theory, they talk about Madame Curie all the time. Anyway, Curie is a common unit measure of the activity of radiation. Okay, an RBE, relative biological effectiveness of ionizing radiation. Okay, just know what that is. It's the relative biological effectiveness of ionizing radiation. Okay, kilogram, a coulomb per kilogram, measure radiation's ability to produce ions in the air. Okay, pretty simple. A becquerel measures radiation activity or the number of particles emitted per second. Okay, and air Kerma. I always think of Kermit the Frog when I see that, and I don't know why. But air Kerma, Kerma stands for kinetic energy released per unit mass. Okay, and it's a measurement of the energy released when a photon passes through the air. Okay, so you'll see air Kerma show up every now and then in your studies. It's just the measurement of the energy released when a photon passes through the air. Okay, so enough of that stuff. So radiosensitivity effect. We deal a lot with radiosensitivity. Okay, so an oxygen effect refers to the phenomenon where cells are significantly more sensitive to damage from ionizing radiation when oxygen is present. Isn't that interesting? So if oxygen is present, the tissue is much more sensitive to damage. Okay, and this one's kind of a mortal one. Anyway, LD50. The amount of radiation required to kill 50% of the population within a specific time frame. Now, we're not going to be dealing with anything close to that. We're talking about Chernobyl type stuff. It's the amount of radiation required to kill 50% of the population. Okay. Deterministic effects. Okay, refers to predictable effects at certain radiation dose levels occurring when enough radiation energy disrupts the tissue. Severity of damage will increase as doses increase. So keep that in mind. Deterministic radiation, it's predictable. So the amount of mass or kV that we use is directly proportional to the damage that we do to tissue. Okay. The stochastic effects, it's probabilistic effects, effects that occur by chance. The probability of this effect increases with the dose increase. Okay, so just remember that deterministic is a predictable. It's the technique that we set determines what's going to happen to our X-ray as it passes through the body, where stochastic is probable effects. So, and these effects occur by chance. And the more dose you use, the more you're looking at the deterministic effects and stochastic effects. Okay. So what I need to know about SI units in radiology, like I say, those things that I just went through, you just be familiar with what they are and what they stand for. Okay. We need to know the main units of measurement that are used in measurement in radiology, whether it be sieverts and grays or rads and rams. Okay. Just be familiar with it. Equivalent dose. The damage caused by radiation to tissue depends on the type of radiation that is incident on the body and the anatomy that is irradiated. Okay, so the equivalent dose is the amount of radiation that causes the damage. Okay, effective dose estimates the risk that radiation will cause detrimental stochastic effects, i.e. cancer. Okay, and you know we talked about stochastic. It's totally by chance, and it doesn't happen to everybody, but can happen. Okay, absorbed dose, the dose quantity, which represents the specific energy deposited by ionizing radiation in living matter. So absorbed dose is exactly what it says it is. It's the quantity of radiation that is deposited by ionizing radiation in living matter. Okay, here's a little bit of a conversion table. So rad equals gray. 1 rad is equal to 10 pracoi. 100 rad is equal to 1 gray. So 100 millirads is equal to 1 milligray. Okay, just be familiar with that. It's not going to be the end of the world if you don't know that, but it's interesting anyway. Let's move on. Okay. All right, just a little break from that stuff. Let's talk about exposure. So when we're selecting our techniques and we are exposing that patient to radiation, okay, we need to understand that there's something to that, and it can be dangerous in higher doses. So always keep that in mind when you go to do an X-ray, that we want to keep things as low as reasonably possible, okay, or achievable. So there are 2 main methods of increasing exposure to the patient, meaning the opposite will decrease the exposure to the patient. So increasing the mass, the MAS, the milliampere seconds, or increasing the quantity. And we know from last week that quantity equals mass. It's the quantity of X-ray photons that are passed through the body. So increasing mass or increasing the quantity of X-rays produced, more X-ray photons will pass through the regions of fixed size, okay, or the body. If we want to change the quality of our beam or change the energy of the X-ray photons, we will increase the KVP, okay? And we will get into this a lot deeper when we talk about technique stuff. But we know to increase the quality of the beam or change the energy of the X-ray beam, we need to raise the KVP. If we increase the KVP and leave the mass at a fixed area, there will be an increase in the average energy of the photons passing through the body or region of fixed size. This will create a higher energized beam, and more energy will be deposited to the patient, i.e. the patient will receive a higher dose of radiation. Okay, the beam is intensified and the photon production is increased. Okay, very, very cool. Conversely, the KVP and the mass is decreased. The average energy of the beam is decreased, and the number of photons is decreased, therefore lowering the dose of radiation administered to the patient. Okay, pretty cool stuff, and we will talk more about that. Especially, when you guys are doing X-rays, try to think about exactly what the KVP and what the mass is doing. We know that the KVP has everything to do with the quality or the energy of our beam, and we know the mass is the number of photons that we're releasing out of the X-ray tube. Okay, and more X-ray photons equals more dose for the patient. Okay, let's see, somatic effects of radiation. Physical damage caused to the body tissues and organs from exposure to radiation. Somatic effect occurs in the body's regular cells. Okay, so some acute effects of radiation or short term: skin redness or burns, nausea and vomiting, hair loss, fatigue. Now, I want to quantify this, but by saying we're not dealing with this much radiation. Okay, we're not going to see these acute effects with what we are doing. Okay, like I say, if somebody is undergoing radiation therapy for cancer, they may see some of these. I've seen cancer patients that have skin burns from the amount of radiation to a specific area, and it can make you sick, make you lose your hair, and some severe fatigue. Okay, acute radiation syndrome or acute radiation sickness, pretty bad stuff. These are some of the symptoms for acute radiation sickness: weakness and fatigue, confusion, nausea and vomiting, vomiting blood, diarrhea, rectal bleeding, fever, skin tenderness and swelling or burning, and hair loss. Okay, so we can see that the radiation sickness is no joke. We look at patients that are undergoing a lot of radiation for cancer. They're dealing with some of these things, and I just want you guys to know the importance of radiation safety, which we'll dive into here in the next couple of weeks. Just keep your patients safe and keep yourself safe.
Hey, Eric, I have a question.
Yeah.
Can you test how much radiation a patient has in their body if they're getting that sickness?
That is a good question. I think the only way you can do that is knowing how much radiation they've actually had, which is tough. I mean, us as occupational people, we wear dosimetry badges. Okay, that's telling us how much radiation we've been exposed to. Now, as far as how much a patient has been exposed to, that's kind of hard, not knowing history. But that's a good question, though. I don't know if there's an actual way for us to figure that out. I'm sure there is. Let me look into that a little bit. That's a good question.
Okay, thank you.
You're welcome. All right, so somatic effects of radiation continued. Late or long-term effects of radiation exposure: increased risk of cancer, thyroid cancer, leukemia, and cataracts. And that's what I worry about. When I was a young tech 20 some odd years ago, I didn't understand this very well. And I used to go out and hold patients without protection a lot. And, that does worry me going forward, because we know that radiation is accumulative. What you've been exposed to is what you're exposed to. And it can cause these things. And it's totally stochastic, meaning it's totally by chance that one of those radio photons affected a cell and maybe didn't kill that cell completely. It just made it malform. And when that malformed cell actually reproduces itself, that's where cancer starts. So take care of yourselves and take care of your patients. When you go out there to hold a child, put some lead on, okay? Because you do it more than you think you do. And that's just radiation that you're exposed to. that can lead to these things. I'm not saying that we're all going to have cataracts or cancer or anything like that, but it's important you understand that there is protection from that, and we need to use it. So organ damage depends on the area exposed. Fibrosis, which is the formation of fibrous tissue, which can be very dangerous. Impaired cognitive function. Sometimes I wonder, man, my cognitive function isn't great sometimes, and I hope it's not from overexposure radiation. But anyway, factors affecting severity of somatic effects. Come on, there you go. Radiation dose. The higher the dose of radiation leads to more severe somatic effects, and that's just common sense. The higher your doses, the more of a risk you have for those effects. Exposure duration. Prolonged exposure can increase the risk of somatic damage. With the x-rays that we take, all of our techniques are really short exposure times. And unless you're doing an advanced type rib x-rays or something, when you're going to use a little bit longer exposure. But you just need to know about this. The exposure duration is important. Exposed tissue type. Rapidly dividing cells are more radiosensitive, and they're more sensitive to radiation damage. Okay, so it all depends on the type of tissue. Individual susceptibility. Genetic variations can influence how someone responds to radiation. Okay, we'll talk about that a little bit more. As a rule, body tissues that divide more rapidly are more sensitive to radiation. The most sensitive tissues include blood-forming organs like bone marrow, reproductive organs, testes, ovaries, very, very sensitive to radiation, just because they're always producing. They're always doing something. Skin, it can become red, dry, swollen, develop sores. Epithelial tissue, the lining of the small intestine, for example, very radiosensitive, which is crazy to me. Hematopoietic cells, immature cells that have divided from stem cells. Okay, so blood cells. And the least sensitive tissues include the nervous system, central nervous system, muscle tissue, those that are no longer undergo cell division in adults. Okay, those are least sensitive. So the factors affecting tissue sensitivity, cell proliferation rate. The faster the cell divides, the more sensitive they are. Okay, i.e., ovaries, testes, reproductive organs, the inner lining of the small bowel, thyroid. Those are very prolific cells, so they're going to be more sensitive. Cell differentiation, which means the process by which less specialized cells develop into more specialized cells. The more differentiated the cells, the less sensitive they are. Okay. Tissue age, older tissue and organs are more resistant to radiation. So we say resistant, not sensitive. So the older you are, the less, or the older your tissues are, the less sensitive they are. Okay. Metabolic activity, tissues with lower metabolic activity are more resistant to radiation. Okay. Radiation can damage DNA of the patient, which can lead to cell death in cancer. And I talked a little bit about that, cell being dysmorphed and multiplying in that manner, which can be scary. Children and adolescents are more sensitive to radiation than adults are. Okay, and we kind of all know that. When we have a child in there, we need to cover them up, protect them. Okay. Okay, embryos and fetuses. Okay, we ask this question all the time: are you pregnant? We need to be constant with that and keep on whether a patient is pregnant or not, so we can properly protect them from radiation. So embryos and fetuses are considered highly radiosensitive due to their rapid cell division and differentiation during development. This makes them more vulnerable to radiation exposure, especially during the early stages of organ development. The first trimester between weeks 2 and 8 are the most sensitive. Okay, that's when the most cell division is happening. Where relatively low doses can lead to significant developmental abnormalities and potential health malformations and consequences, as well as growth restrictions and impaired brain function. So it's important. We ask that question for a reason. And like I said, we need to do that so we can protect that unborn child, especially between weeks 2 and 8. But that's just what they say. I just say if they're pregnant, cover them up, unless we are imaging those areas, we can't cover them up. Okay, and like it says here, relatively low doses can lead to significant developmental abnormalities or potential health malformations. Okay. So a key point here, use lead protection on pregnant women and those of pregnancy ages. Okay, whether they say they're pregnant or not, we should be covering them up. Okay, according to the National Institute of Health, as well as the ARRT, which is the American Radiology Registry, okay, or the American Registry of Radiologic Technologists. Childbearing ages between 12 and 50. And we're going to hear different things, 9 to 55, or but as a rule of thumb, 12 to 50. That's what the National Health Institute says, as well as the ARRT. So any testing questions, it's going to be 12 to 50. Okay. So it's hard to ask a 12-year-old if they're pregnant, but that's something that we need to do, and it might be embarrassing for them, but it's okay. It's important. So radiation biology. So we already talked about deterministic effects, those in which the number of cells lost in an organ or tissue is so great that there is a loss of tissue function, okay, i.e. skin, erythema, or ulceration. Stochastic effects occur in an irradiated cell, modified rather than killed, and I talked a little bit about this, and then goes on to reproduce. Okay, that's where it gets dangerous. There does not appear to have a threshold, and the probability of the effect occurring is related to the radiation dose. Okay, and you'll hear me talk about a LARA, as low as reasonably achievable. There's a fine line there between dose and a good diagnostic image. Okay, and that's something that we'll learn going forward. Keep that dose as low as we can, so we're not harming the patient as we would if we were using a high dose. Okay, hope that makes some sense. Okay, and as a radiologic technologist, does not simply push a button. Some people call us button pushers, which is upsetting because you guys are seeing that there's a lot that goes into taking X-ray and studying for a test on X-ray. It's not just pushing a button and setting a technique. There's a lot that goes into it. If we take anything away from today, just know that radiation can be dangerous when used improperly. Okay. And that's what we're here to learn, is to properly administer a dose of radiation to a patient to get the best image that we can. Okay, and that's what we're going to learn. Just always keep that in the back of your mind, that it is dangerous, and if we have a chance to use a lead, use it. Okay, you'll either be standing behind the control wall, or you'll have a lead apron on helping hold the patient. And it's hard when you're in a hurry, or just want to get you've got a child in there that's screaming. Sometimes that's hard to do. And I'm guilty of not covering up. And but it's a good idea to take care of yourself, especially if you're a female worker and you're pregnant or at pregnancy age. Take care of yourself. Also, one little tidbit: if you do become pregnant, let me know so I can get you a fetal monitor. Okay, because we need to be monitoring how much radiation is going to your fetus as well as yourself. Okay, so if you guys have any questions, please reach out. I'm happy to answer them, like the question that was proposed today. I do appreciate the question, and I will look more into that as far as measuring how much of a dose people get. So anyway, have a good day, and I appreciate you guys being here, and we will talk next week. I think we're going to get into some radiation safety stuff next week, and whenever Kate and I can get together, we'll get another video out. We've been going different directions. So anyway, thanks guys. Have a good day. See you later.